to a friend and colleague who is one of the major headache players in the United States and the world, and has a very enlightening and interesting background, originally coming from India, but doing her undergrad and neurology work in Henry Ford Hospital in Detroit, Michigan, where she became chief president, and also a fellow in headache and neurophysiology. She has been the director of the Headache Center at Henry Ford from 1996 to 2000. From there, she was co-director at the Swedish Headache Center in Swedish Neuroscience Institute in Seattle, Washington, eventually becoming the director for a period of 8 years. She has been assistant professor at the University of Buffalo, then a clinical associate professor. She worked at Eli Lilly, so she went over to the industry and worked at Eli Lilly as the medical fellow and launch leader of a CGRP monoclonal antibody, and now is vice president of medical affairs at Impel Neuropharma, which is a smaller company, but with a very intriguing new medication that Sheena Aurora will be talking about. So without further ado, and I should mention that her resume includes too many articles to review, but she has published with the major giants of headache medicine all through her career. And she actually has, I think, sent important articles that she's published in neuroimaging and headache medicine. So with great privilege, I would like to hand over to Sheena Aurora, who will be talking about DHE Farmakológia.
Thank you so much. Good morning. And I wish I had learned at least a hello in Hungarian, but next time. Szia. It's a privilege to be here. I think that in terms of clinical practice, this is the gold standard here. So I feel very privileged. What I'm hoping to do in the next maybe 30 minutes or so, just take you a journey towards dihydroergotamine. I know a lot of it gets used in at Dent here, and also my colleagues thought that this would be a worthwhile topic. So to advance this. Yeah, great. So just here are my disclosures from a CME perspective. I'm a full-time employee and a stockholder in Impel Pharmaceuticals. So had the privilege of listening to Dr. Mesylate yesterday, and I smiled when he said claviceps purpura. So when we think about how dihydroergotamine originated, it originated in the 40s. And I think what's really important about that is all over the world, sometimes it still gets confused with ergotamine, and we know that ergotamine was useful in the headache practice. However, it has some side effects, and so this is a unique attribute in chemistry where just by adding 2 hydrogen ions in unique positions, you can change a drug profile by a tremendous amount, so you get more clinical value. So dihydroergotamine versus ergotamine, they're very important differences, because by just that hydrogen bond on the 9-10 phenol ring, right, Rob? Okay. I have a colleague here, Dr. Van, who has a PhD in neurophysiology, and so I'm going to rely a little bit on other brain power as well today. So because of that, there is not that much vasoconstriction seen, because if you give somebody ergotamine, or when it was noticed that patients or subjects ingested that claviceps purpura or that fungus, that they either got a peripheral system of gangrene, or they they had uterine contractions, so it was used as an abortive agent as well. But because of those two H ions, you actually add that you continue that pain relief that you see with migraine, but now you have a reduction in the vasoconstriction compared to ergotamine. You still continue to have the venoconstriction, but you have less nausea and vomiting, you have less uterine effects, and lo and behold, the uterine, the whole aspect of the headache rebound goes away. So it's been quite a journey to get efficacious DHE in the hands of patients. So here's the overall development. So we've been using dihydroergotamine in the clinic worldwide since 1946. This was approved. I think the trouble is how to get it into the system. So in between between 1946, there was a formulation, and it still exists. It's called Migranol. It's the intranasal, and we'll talk about what the differences in anatomy are very, very briefly, because I do want to focus on pharmacology and pharmacokinetics this morning. But the pharmacokinetics change dramatically when you're delivering the DHE to the middle and the lower nasal space because of the proximity to the tract. And we all know that DHE swallowed goes 98% of that lands up in the toilet because it's not absorbed well in the gut. And so we've been able to circumvent the gut and deliver the DHE into the upper nasal space. So we'll talk a little bit about that. And so we go from this bioavailability in the IV, which leads to 97% pain freedom. We can rely on this drug consistently in the clinic. So there was a drug developed in the late 1990s, early 2000s. In fact, I was the principal investigator for this, which is called MAP-004 compound. And one of the challenges of DHE is it's unstable when exposed to sunlight or mixed with the propellant. So when we talk about the INP-104, one of the ways our Chief Technological Officer, George Hochman, has been able to make this delivery so consistent and efficacious is that the propellant and the DHE are not mixed together, because that's what happened with MAP-004, and so it never came to fruition. Also, to let you know that there are other DHEs that are in development of note, STS-101, DFN-19, there's also a microneedle patch, there's a sublingual, and there is another orally inhaled one. So more to come on that. I think that there is a tremendous opportunity for having patients get access to DHE at home. So if you think about the model for migraine, there we go. So if we know that migraine pathophysiology is very, very complicated. We see that, you know, for the majority of their life, if you're looking at somebody with episodic migraine, they have long periods of relief, or the interictal period. But even that has a comorbidity of anxiety, because patients are wondering when their next attack is coming, you know, how much disability are they going to have? So in terms of this whole aspect of where DHE might work, one is it has an anti-nausea activity via the D2 receptor antagonism. It can also work during the aura phase to relieve the aura, and we'll talk about some of the receptors. And again, dopamine is one, and I don't know how much you've seen this in clinic, but when I was in practice, some patients had yawning as a prodrome, and those patients, I felt hypothetically didn't respond to the triptans, because I think they had a lot more dopamine receptor activity. DHE also has an activity on the 5-HT2A receptor. It also has antagonistic activity on the D2 receptor and some of the hypersensitivity reactions that patients might have, or that increase in excitability like phonophobia and photophobia may actually get relieved by that. DHE also binds to the epinephrine type B receptor and is implicated in improvement of memory. And these are all things that are hypothesis on where they fit into this continuum of migraine pathophysiology. But we know from clinical practice since 1946 that DHE seems to work when other acute medications don't work. So the receptor profile was extremely important for us to identify. So there are some central effects that have been shown to reverse the central sensitization, and the whole aspect of where DHE may work in the inflammatory soup. It also has an activity by suppressing the CGRP receptors and activation of the alpha-2. So at Impel, my colleagues and I thought that it was really important to discern these activities, because prior to this, there were some radioligand studies that had been done that had showed that the orally inhaled DHE had a better receptor profile in terms of side effects. So that's an article that was published by Robert Cook. So if you look overall on migraine pathophysiology, you can see that there's a wider range of receptor activity. And we know, despite innovation in CGRP, so CGRP is, of course, very, very keenly associated with migraine pathophysiology, but it leaves a whole lot of unmet needs, because you can see from the previous slide the wide array of receptor pharmacology and the wide spectrum of migraine pathophysiology that's been associated with different clinical syndromes. And you can see where all these receptors, particularly what I'd like to point you out to is receptors outside the 1B, 1D. So we know that the triptans work here in the 1B, 1D. The ditan also works on the serotonin receptor, but predominantly the 1F receptor. But it leaves a whole lot of receptors that we know have a very big association with the migraine pathophysiology. What you can see here, the raphe nuclei, you can see the area postrema. So that's where we think, because DHE, our hypothesis going into this was that DHE has a wide range of activity outside the 1B, 1D, including CGRP, that may be very important. So radioligand binding assay, many of you are probably familiar with it more than I am. I'm not a basic neuroscientist, but you can see here that those pathways have alluded to these various receptors outside the 1B, 1D, so the 1B, the 5-HT3, the 5-HT4E, and the dopamine receptors D2 and D5. So what we sought to do was find a different way of doing a high throughput assay. And one of those is using the beta-arrestin pathway. So what we did of this is we used this particular way, this company, it's called Eurofins, and the way they work is that using beta-arrestin, it's the protein that plays a role in the GPCR signaling. So once we get a cell line of that, we can see where there's activity of different compounds. So this is the analysis, the beta-arrestin pathway that we use to measure the activity of DHE. Now, one thing that I will tell you was not such a strong aspect in this pathway, that they don't have any cell line for the 5-HT1D receptor. So we did a separate analysis looking at sumatriptan so that we could actually confer the activity of beta-arrestin and compare it to DHE and sumatriptan to overcome the drawback that they did not have a cell line for the 5-HT1T. So anyway, this paper is going to be hopefully coming out soon. We do have it in an abstract form if you're interested in more of this pathway. So what this pathway does is, if there is activity more than 30%, that's conferring agonism. And if there is an inhibition of more than 50%, then we consider that to be antagonist. So here you see the activity. And I think for the clinicians, what's important is to note that the 1B receptor, you can see this agonistic mode here for DHE and sumatriptan. So it's right there, right? So we can say that we've got the biological activity so that hypothesis of the anti-migraine activity is clear. But then you can see versus sumatriptan that the DHE has a lot more agonism here in the 5-HT2A, 2C, and the 5-HT5A, as well as alpha-2B, and I'll explain why there may be some clinical relevance there. Now, you might think that 52% 100 versus the 115% of sumatriptan may be clinically relevant, but we don't know the clinical relevance. I think the importance here is that bar, that the agonistic mode is more than 30%. So what does this clinically mean? So the agonistic activity at D2, when nausea is a symptom of migraine, we can say that that here we at least are not going to probably see as much nausea, and we can also confer this with some clinical data that we have collected, and it's all to do with how that D2 receptor becomes engaged. So if you look back at the results of the radioligand binding with the IV versus the orally inhaled, the D2 receptor becomes very, very different depending on the level of DHE. So this level of DHE, there's actually an agonistic activity on the D2 receptor. We also saw agonistic activity on the alpha-2B receptor, where this label of DHE is that it may warn against the potential vasoconstriction and the transient increase in blood pressure. So this agonism is very important because we've got this notion that DHE is so much more dangerous than the triptans, but you saw that 1B receptor, which is very similar to the activity that is seen with sumatriptan. There's a wide range of papers and research and meta-analysis that we do not believe that for most healthy patients that there is a problem. Of course, there is a contraindication with patients who have cardiovascular disease. But here, again, clinical relevance is undetermined. But just from a pharmacology perspective, the agonism of alpha-2B may not necessarily result in hypertension. Then, of course, we have the 1B receptor. We know that the 1B receptor has been linked very well to the activity that we see for the migraine and for alleviating pain. So as I mentioned, a limitation is that the cell lines didn't exist for 5-HT1D. So more to come on that. We will be hopefully doing more on this. So I hope folks in Europe, because you've got the time advantage, I'm sorry that this was a big, heavy chemistry lesson. It was a little difficult and challenging for me as well. I'm not a basic scientist, but from a clinical perspective, I think the take-home message is that DHE works on a wide variety of receptors that have been associated very keenly with the mechanism of migraine, and perhaps particularly where there's a huge unmet need, where patients are not getting the efficacy that they deserve. and they do get it with DHE is because of this wide spectrum of activity, particularly from this particular analysis. We've noticed activity on the D2 and alpha 2B receptor, but continuing to see that activity on the 1B receptor. So we've talked about the DHE molecule and how beneficial it is. And clinically, what we see is when given in an appropriate way, very consistent way, like the IV, that it has fulfills the unmet needs of patients waking up in the morning with migraine, patients who have resistance to. Now, by the way, we've also seen that with the G-pants, because there's a lot of cycling going on. And I personally believe that one, it's because there isn't enough of a coverage in terms of receptor pharmacology, but two, it's the oral route where I think that there is a lot of autonomic dysfunction. And I'm very pleased to see that Dent is going to have the gut-brain center. I think it's a much needed space for patients to realize that they have autonomic dysfunction and that oral medications may not work all the time. We haven't talked about the pharmacokinetics. I'm going to talk about that next, that there is a long half-life. And so DHE may also work for menstrually associated migraine and those patients who don't take it in a particular window where there's a lot of central sensitization and allodynia that occurs. And there is very minimal risk of medication overuse, again, because of those two hydrogen ions. So when we talk about pharmacokinetics, one of the big problems with the interim between 1946 and I would say 2021, when the nasal delivery pod came out, the precision olfactory delivery system, you can see that the bioavailability of the IV is 100%. The lower nasal space, as well as the IM and sub-Q, we don't even know what the bioavailability is. One, these were very slow. So we went from a Tmax of 1 or 2 minutes to 30, 45, and then 60 to 120 minutes. So it really didn't, the huge unmet need that occurred between the IV DHE and fast forward to last year was there was a big gap there in this development. So when one of the signals that we had that DHE does work outside this window was from the MAP 004 study, where you can see that the patients actually used a stopwatch, and this was the efficacy seen within 2 hours. If patients took the drug within 1 or 4 hours, that efficacy was still seen. It was seen beyond 4 hours and even beyond 8 hours. Now, naturally, the longer you wait, it does have, it loses its big efficacy within the 2 hours. But these kind of results, where if you look at the triptan studies, they drop precipitously. DHE works outside those windows. And one is, it was the formulation, it's the pharmacokinetics, how DHE was delivered with that Tmax, but also the wide array of receptors. So we know that this is again from the MAP days, that we have that long lasting effect of 24 and 48 hours relief. One of the big problems with patients going to oral medications and medications that don't work effectively all the time, that patients tend to redose. That leads to medication overuse, leads to chronification. So it's very important when you find patients in your clinic that have this problem of overusing medications and not getting that efficacy, to address that and put treatments in their armamentarium or their toolbox so that those are addressed. So we know from the mid-50s that DHE administered effectively stops the cycle, is used as stopping status migrainosus, stopping medication overuse. So that led us to continue to get DHE more effectively. We also know that DHE works in menstrually associated migraine. If you think about a trigger that persists and where, again, the oral medications and medications that target in a very narrow way, as well as medications like the triptans and the gepants now that have a half-life of like maybe 5 to 6 to 8 hours, 10 hours. When you look at the DHE, again, effectively, when given, the half-life is approximately 10 hours. And so for a migraine like menstrual migraine, there is a huge problem where patients tend to continue to redose. Let's talk a little bit about this central sensitization and with allodynia. And so allodynia is a clinical hallmark of central sensitization. We know that the trigeminal vascular system is particularly prone to have a wind-up phenomenon that occurs. So patients, I think the questionnaire that was done, the most sensitive was that patients have trouble brushing hair. And for the most specificity, men couldn't shave their face and women had trouble with their necklaces. So when you think about that whole aspect that I just showed you with MAP 004, it became very important to have drugs that work outside that period of allodynia development or central sensitization. And again, it's the half-life as well as the receptor pharmacology that makes DHE fit that bill of treating the patients outside those windows. So just to talk a little bit about the differences between the upper and the lower nasal space. If you think about migranol, it's like almost like, or any of the delivery systems before the precision olfactory device. The way I describe it to patients is it's like taking a tablet in your nose, because the lower nasal space is so connected to the GI system. So the whole aspect of trying to meet the needs of patients effectively, giving them a non-oral route, which didn't have to be an IV, was a huge hurdle to meet, because there was a lot of drip that occurred in the front, as well as a lot of drug that got swallowed. So our chief scientific officer took the MAP compound, took the learnings from it, and decided to put dihydroergotamine in his delivery system, which is the precision olfactory delivery system. And what this led to was that we were able to reduce the dose of DHE to 1.45 milligram compared to 2 milligrams of migranol, improve the bioavailability by fourfold of migranol. And that's really because we are targeting the upper nasal space. Watch this space. There is another formulation that is being studied. It's a powder. And it's using quite a high dose of 6 milligrams. So when we did our program at Impel, we kept the dose to 3 doses per week, because we wanted to be under the threshold of 6 milligrams. So this 6 milligram STS 101 that's in development may have some issues. In fact, there was a placebo-controlled study that was done which did not meet its endpoint. I can say, from being a researcher in this field for a very long time, DHE is very tricky. There is a sweet spot where the receptor engagement needs to occur, and beyond that, it in fact loses its efficacy. So more dose doesn't mean better efficacy for DHE. So this upper nasal space, I was wondering, but when I joined the company, how I was going to explain it. And then a convenient pandemic occurred, which has been devastating. But what it allowed me to do was explain where the upper nasal space was. And so it's a highly rich vascular space. And let me see if this is going to play.
Traditionally, nasal drug administration has focused on delivery to the lower nasal space, which is associated with significant drug loss from the nose with existing delivery systems, which may lead to variability in absorption. In addition, Deep inspiration associated with existing systems can collapse the nasal valve, essentially blocking access to the vascular-rich upper nasal space. Traditional Impel Neuropharma's pod technology is a handheld, manually actuated, gas-propelled administration device uniquely designed to gently deliver drug to the upper nasal space without requiring breath control by the patient. With pod technology, the proprietary nozzle design allows for a narrow, targeted plume of drug to effectively pass through the nasal valve to reach the rich vasculature and expansive surface area of the upper nasal space. The two-step action of the propellant launches the drug and then pushes it far into the upper nasal space. The upper nasal space is a unique and underutilized environment for drug delivery. The ciliated olfactory epithelium in this richly vascularized space makes it ideal for rapid absorption into the systemic circulation, potentially leading to a faster response than oral medications. Potential benefits of delivery to this space also include the reduction of drug-related adverse effects and the potential avoidance of delayed absorption in the GI tract and first-pass metabolism in the liver.
Okay, so this product was called INP104 in development. It is now marketed in the US. I'm a huge DHE proponent, and I'm a global scientist. So I'm hoping at some point we can bring it to Hungary and to Europe. But at the moment, it is really fulfilling that need for effective DHE at home. And that the so what behind the delivery system is, if you look at this particular graph, this was a three-way study done in 30 healthy volunteers who were all given IV DHE. So this is the IV DHE pharmacokinetic curve, as you've seen before, and as we've discussed this morning. It's got a very quick Tmax and Cmax. You can see again, this is migranol here, which delivered to the lower nasal space. There's a lot of wastage of drug that occurs. And you can see then in red, Trudesa or INP104, which mimics that area under the curve of the IV, which is actually associated with all the receptor binding that we talked about this morning. So compared to migranol, we've been able to increase the area under the curve to mirror the IV, and hence we are seeing quite a lot of good consistency in the clinic now. So just in terms of the PK parameters, if you look at across what's development in the DHE arena, what I'd like to draw your attention mostly is to the area under the curve. And you can see here migranol 387.5 compared to DHE IV, which was 3022. You see MAP, which was again very effective in the clinic. The reason it never came to market was because of the instability that hurdle of manufacturing was not achieved. And you can look here with INP. But what's also important is the dose. So we are getting this area under the curve of 1603 with a 1.45 milligram dose. The STS-101 powder is using 6 milligrams to get that dose. So that's probably one of the reasons that their placebo-controlled study failed, because again, getting more dose may lead to more side effects and less efficacy. We are continuing to develop new, because this is our first generation device that we took all the way to the development. We understand that it's a bulky device. It also, the recycling purpose is not fulfilled, etc. So we're continuing to work on this delivery device so that we can make it more efficient, etc. And continuing to develop other drugs that target this upper nasal space. Our next drug that we have in development is olanzapine for something which is very near and dear to my heart. I have a son who's on the autism spectrum, so we're working on that to reduce spells of agitation. So just to wrap this up, what I'd like to show you is some clinical parameters that we've collected. This was an open label study using our drug INP104, and we recruited 354 patients. We asked them to keep a diary at baseline, and they were using their most effective treatment. And you can see it was a wide array. And again, you can see, and obviously as clinicians, you know that there is a huge unmet need. So here are some of the exploratory efficacy measures. So very akin to what we've seen with IV, we see very good pain freedom results with Trudhesa compared to best usual care. We also see early effect of pain relief and 66.3% of pain relief at 2 hours. We continue to see that promise of that interaction with the DHE pharmacology, where very few patients need rescue medications once they get on INP104. And further, even outside that treatment window, when we talk about central sensitization or delaying treatment, we continue to see efficacy beyond 2 hours and beyond 4 hours. We also see a lot of consistency of effect. Time after time, there seems to be this pain relief where more than 75% of the attacks that were treated had pain relief. We also see that it's well tolerated. So compared to Migranol, we don't see a lot of nausea. We see that the most common side effect is local, it's rhinitis. We also did upper endoscopies, smell tests, because we were the first, according to the FDA, that went into that upper nasal space. We also collected EKG parameters, blood pressure parameters. We saw no new signals where CV safety was concerned. So I'd like to leave you with this, that DHE is stalwart in our need for migraine treatment. We have not had a molecule that's replaced that rescue or effectiveness that patients need when their drugs fail. Also, it should probably be in everybody's armamentarium, because they're going to have they're going to have a migraine attack that they're not going to be able to catch early, particularly early morning migraine. They're continuing to have a lot of attacks that need repeat dosing, like menstrually associated migraine. So that definitely is something where we continue to need DHE in our armamentarium. So I will stop here and answer any questions and bring Dr. Mesylate back. Again, it's been a huge, huge honor. As Dr. Mesylate mentioned, grew up in India, so namaskar, and hope to see you all soon.
Thank you very much, Sheena. So in the United States, we have a new world with the CGRP monoclonal antibodies and the CGRP antagonists, which are not presently used in Hungary, I should say. DHE is an old medication that's been around many years, developed by a combination of Sandoz and Ciba-Geigy, and then eventually Novartis. It's an old medication, but in headache centers around the United States, it is probably one of the primary drugs we use for the treatment of status migrainosus. And there's a protocol that was developed many years ago in California called the Raskin protocol, which uses dihydroergotamines. So it is very important in headache centers to use DHE, but this is something that allows us to treat as an outpatient quite easily. So as I've mentioned, in our headache center, we're major proponents of this drug. So maybe I should ask some questions from my Hungarian colleagues. Is DHE being used in Hungary right now, actively or not? Let me see who is over there. Well, most of everybody here is from the United States. Adin, Havas, so Robertson. So, by the way, these lectures are being taped, and you can go to the Mind website and look at it and review it once more. So, unless there's any further questions, hey, Jerry, from Rochester, you got a question for us, Jerry? He's gonna probably seeing patients about now, right? All right, so without further...
Yeah, no further questions. That was a really good presentation.
Well, thank you, Jerry, for your comment. We really appreciate it. We miss you, you know that.
Nice to see you.
All right.
Thank you.
You look so large. So, all right, well, Dr. Linkoff is a neuro-ophthalmologist, colleague of ours. Nice to see she's on board. Again, thank you for your, I wish the residents at UB could be able to see this lecture, so maybe they can get onto the website and review it. I see Dr. Cycley's here too. So again, thank you very much, Sheena. Yeah. We'll look forward to the next lecture, which will be in a month from now. We'll send out emails notifying you who will be lecturing. It will be Dr. Bolashov, who is a well-known MS specialist in the United States. He'll be talking about multiple sclerosis and new treatments. Thank you very much. You have a nice weekend, and look forward to seeing you in a month from now.